I definitely wanted to thank Phil Martin and the Academy for inviting me and inducting me as a new fellow. It's a big honor. I have two pre-talk things to say, and one is that even though I'm affiliated with Colorado State and proud of it, it's been a total of 3.5 weeks, whereas there were 14.5 years before that at the University of Massachusetts, and clearly the work I'm going to talk about did not occur in the last 3.5 weeks, so sorry, Jeff. But I really wanted to give credit to two department chairs that I had who really created an environment that allowed me to be successful, and that's Patty Friedson and Joe Hamill, who really facilitated my career in innumerable ways. The second thing is, full disclosure, I've had 2 concussions, one at age 21 and one at age 35, so whatever I say that doesn't make sense, I'm attributing to those traumatic head injuries and not to any lack of insight on my part. I don't have an outline. I don't use outlines because that would constrain me to actually talk about what I said I was going to talk about instead of anything that pops into my head. So I'm going to go with the no outline. So our lab mission, which really matches up with this theme in a really nice way, has been metabolic rehabilitation. We shamelessly stole that from physical rehabilitation and just applied it to understanding how diet, physical activity, and pharmacology can be optimally integrated to reverse insulin resistance and hopefully prevent type 2 diabetes. And we've tried to stick to that mission for the time that we were working there. So these are the physical activity guidelines, or a short version of physical activity guidelines for all Americans. And I'm not going to say anything bad about them because most of the authors are in the room. But I did want to point out a couple of things that I think are relevant. And one is that some physical activity, we're all familiar with this, some physical activity is better than none. Adults who participate in any amount of physical activity gain some health benefits. They should do 150 minutes a week, or 75, or an equivalent combination. And preferably, it should be spread throughout the week. And for additional and more extensive benefits, you could do more, or an equivalent, or something beyond this amount. And you should also do some muscle strengthening 2 or more days a week. And this, of course, is really reasonable stuff, but it got me thinking, and my graduate students thinking, what if we prescribed actual medications in this same way? And that when you went to your physician, and the physician tried to lower your blood pressure with an ACE inhibitor or a calcium channel blocker, this is the prescription they would give you. Take a few pills, it's better than none. Try to take at least 3 of these pills most of the time, and you'll feel even better if you take more. And don't take them all at once, try and spread them out. So I think about our physical activity guidelines, and I'm not giving people a hard time, but this is the equivalent prescription that we're giving people. Take some, if you can do more, that's better, but don't worry too much about it. Anything's better than nothing. Whereas, we've tried to think in the lab for a long time of exercise as a medication or as a drug, with the idea that at a sufficient dose, exercise improves metabolic function, and over time that effect wanes, and you have to take subsequent doses to maintain the effect, just like every other drug. And what that kind of led us down the road was, that if we tailor each dose to get the maximal effect, that will probably give us the best long-term reward. In the same way that when you design any drug, you try to tailor the drug to give you the maximal effect each time you take it. So one of the things that people have thought about for a while is do the effects you have, or are the effects of exercise on preventing or delaying type 2 diabetes, is that due to training, or is that something you get from each acute or single bout of exercise? And Rebecca Hassan at University of Michigan, who both Patty and I trained, this is her favorite study of all time. If you meet Rebecca and you mention Greg Heath's 1983 study, she will love you forever. In which he took a group of highly trained athletes, measured their insulin sensitivity, or at least their insulin response to an oral glucose tolerance test. Low is good, high is bad. Low response, they don't secrete a lot of insulin because they're so insulin sensitive. You somehow get them to detrain for 10 days, and they lose pretty much all of it. Then you give them 1 bout of exercise, measure them again the next day, and almost all of it comes back. So there's this acute effect of exercise, like any other drug. You take it, it works. You stop taking it, it stops working. How long does it last? And this sort of has implications to how often people do need to exercise. And this is another 20-year-old study by Doug King, where he looked at sort of the time course of this improved insulin sensitivity. And again, lower is better, less insulin secretion. This is an exhaustive bout of glycogen-depleting exercise. 1 day later, there's a significant reduction in insulin secretion. 3 days later, it's still there, but it's not there 5 days later. So the effect lasts somewhere between maybe 24 and 72 hours, with 72 hours kind of being the best case scenario. You deplete all the glycogen, you do this exhaustive bout of exercise. This is about as good as it gets. Probably for most people who eat meals, it's probably closer to 24. But it's certainly not longer than 72, meaning people do need to exercise if they want to maintain this benefit at least every 3 days, if not more often. There's some dose-response data from the epidemiological literature, and I can't turn to one side or the other now without thinking of Claude Bouchard's political statement in terms of which direction I'm actually leaning. But a study that Frank Hugh did in the New England Journal of Medicine, I think in 2001, showed that 120 to 240 minutes per week reduced the risk of developing diabetes by 30%. You go up to 7 hours or more a week, and now your relative risk is about half. The diabetes prevention program showed that the relative risk went down below 50% with 150 minutes a week, with that red star reminding me that it wasn't just a physical activity intervention. There was a dietary intervention. There were other parts of this that were a lifestyle package. So yes, there was physical activity, but there were other things as well. Boy, I think we have some rough idea that the people who created the physical activity guidelines, got it right in terms of this sort of 150 minutes a week does seem to be a reasonable dose to get a significant and clinically relevant response. What about intensity and duration? This is actually my PhD work that I did at San Francisco General Hospital in 1995. And we did a study trying to determine, is there an independent effect of intensity and duration on insulin sensitivity? And these are women who had very early onset type 2 diabetes, very insulin resistant. We checked them into San Francisco General as inpatients, controlled every bite of food they ate, controlled every step they took, looked at the effect of exercise over the course of 3 days with every calorie counted, trading intensity for duration. So in one case, no exercise. In another condition, they expended 750 calories at a high intensity, shorter duration. In another case, same 700. I don't even have fat fingers, so I can't even. So in this case, the same 750 calories, but at a low intensity, longer duration. And what we found infusing glucose and insulin in stable isotopes is there was about a 25% increase in sensitivity to insulin, and it did not matter whether the intensity was high or low. The caloric expenditure ruled the day. It didn't matter how you did it. Subsequently, I think that as people have shown more and more impressive results with high intensity interval training, I think I'm already rethinking this, that there may be some additional benefits of very high intensity intermittent exercise that allow you to get more benefit for less duration. There hasn't been much long-term data yet, but the short-term data are really impressive in terms of being able to get effects like this with minutes rather than hours of exercise. So I'm staying tuned for more of that. The other piece of this that I have to admit is, like everyone else in the field at the time, we imposed 750 calories of exercise, but we did not feed back those 750 calories in the diet for two reasons. One, nobody else was doing it, and I was a grad student at the time, so I wasn't going to buck that trend. Second, if you feed back the calories and nothing, and you don't get an increase in insulin sensitivity, who's going to publish that? So there was a self-interest part of this as well. We wanted the exercise to work, so we did not feed back the calories. And in my defense, it at least bothered me a little bit. If you look at the mode of exercise, is resistance training better than aerobic training? Is cardiorespiratory training better than aerobic? I think that's always been an issue. I think Ron Siegel and Norm Boulay up in Canada have really done the best work on this. And this is one of their studies looking at hemoglobin A1C. Again, lower numbers are better for people with type 2 diabetes. No change in their control group over 6 months, 3 months, 6 months. And what they found is resistance training caused a significant reduction in hemoglobin A1c, not just significant, but clinically relevant. That's a pretty nice decrease, 7.5 to 7.2. Most diabetes drugs have about that effect. Aerobic training, a little bit bigger, but there's no difference between these two, and so they're really the same. And then if you put the two of them together, you get a kind of additive effect. And I don't think that's any surprise, and again, harkens back to the guidelines that say if you do more, you'll probably get more of an effect. So resistance training works, aerobic training works. You do both, and you probably do even better. So I said that the not feeding the calories back bothered me, and it did. And I finally got the right student at the right time in the right funding situation, which is rare. And Steve Black, who finished his PhD in 2005, did a study. We did our usual kinds of protocol. We took people who are insulin resistant, pre-diabetes, put them through 7 consecutive days of exercise. In one condition, we gave them the 500 calories a day of exercise, all supervised in the lab, counting every calorie on using indirect calorimetry. And we didn't feed the calories back. And in another group, we did exactly the same thing, but we did feed the calories back. And we fed the calories back immediately upon finishing exercise, 60% carbohydrate, 20% protein, 30% fat. As soon as they got off the treadmill, we fed them back the 500 calories right then and there. And we did that for 7 days. And what we found, wow, I think maybe I lean right. I'm going to have to really rethink this. Is that in the group that did not get the calories fed back, so they have a caloric deficit of 500 calories a day, there's this big increase in insulin sensitivity. They're taking up more glucose at the same amount of insulin. This is not new. I mean, we and other people have found this for decades. But in the group that got the calories fed back, we saw no change at all. Not just a blunted change, we saw no change at all. And we're tempted to attribute this to the fact that if you feed back the calories, you don't see this effect. It's not really exercise. It's really the caloric deficit. But reviewers, several of whom I think are probably sitting in this room, pointed out that we were not really testing just the effect of calories. There's also an effect of the content of the diet. And that by giving people these calories right after exercise with a lot of carbohydrate, we were probably really blunting this effect more than if we'd done this with some other macronutrient. And these data have been around for a long time. In fact, I think Greg Carty's postdoc work was probably represented somewhere up here, where a group of rats exercising to exhaustion. Look at the black bars. That's glucose transport in the presence of insulin. And the sedentary group is here. When you take a group and exercise them and fast them for 18 hours, they're up here. Feed them a high carbohydrate diet, and 42 hours later, they're back to the baseline. But feed them a carbohydrate-free diet, and they're still elevated even 66 hours later. And then Jeff Horowitz did this similar kind of study in humans and showed that if you replace the exercise energy, so here's what happens if you don't replace the energy, here's what happens if you replace the energy, but all lipid, no carbohydrate at all, you maintain that increased insulin sensitivity by restricting the carbohydrate. So it's not just the energy content, it's also the quality or the macronutrient composition of the diet post-exercise that seems to be important. So the advice for athletes to immediately follow their hard exercise with carbohydrate to replenish their glycogen is great if what you want to do is go out and perform another bout of exercise, and probably exactly the wrong thing for people who are trying to enhance their health, because that improved insulin sensitivity is attenuated almost immediately upon refeeding the carbohydrate. Sorry, Gatorade. These data, if I was going to get another tattoo, it would probably be this figure, because this is the Rosetta Stone of diabetes prevention. We'll probably be talking about this study for 40 more years. This multi-center trial, 1,100 people in each group. One group, the placebo group, pre-diabetes, elevated fasting glucose. In 4 years, almost 40% of them have transitioned to overt type 2 diabetes. Bristol Myers Squibb at the time was making metformin without it being generic. They were very happy to see that people taking the drug metformin had a 28% decrease in the transition to diabetes. And all of us, of course, were really happy to see that the lifestyle group had an even bigger reduction in the transition to type 2 diabetes, much more impressive than metformin, and certainly a big difference from placebo. And I don't think it required a leap of great intuition for us to think, well, if one of these things, if exercise works well and if metformin works well, what if we put them together? And this was Carrie Sharoff's doctoral work, where we took metformin and exercise, combined them in a group of people with type 2 diabetes, and looked at insulin sensitivity and did some sort of intracellular signaling as well in terms of AMPK alpha 2. And our hypothesis, and Dr. Jacobs, I'm sure, is laughing at us now, was really simple-minded. If we take something that's good and add something else that's good, you'll get something else that's better, showing that my knowledge of pharmacology is completely erroneous. And, you know, this was a study. We had a metformin group. We had a placebo group. We had exercise and no exercise. And the only thing I wanted to point out is, you know, I think we did a really careful job of controlling the conditions. We had biopsies. We did stable isotope infusions and euglycemic hyperinsulinemic clamps. And the whole point of this is to thank Lori Goodyear, who worked with us in a really very helpful and collaborative way to do the intracellular signaling. And what Carrie found is that in the placebo group, and this is the rest condition, this is the exercise condition, again, the usual 30% or so increase in sensitivity to insulin after exercise. And in the metformin group, one, no effect of metformin itself, but also no effect of exercise. We completely abolished the effect of the exercise when the metformin was taken as well. And for those of you who are saying, wait a second, you have a ceiling effect here. You know, these people, you know, for reasons we have never been able to figure out, the baselines are very, very different in these two groups. So maybe there was nowhere for these people to go. But if I were to put this on a scale where there wasn't a ceiling in the room, this is not a real ceiling. If you were to take people who are lean and sedentary, they're actually up here. If I were to take athletes, you know, they're sort of 10 feet above the wall here. So there's a lot of room to go. This is not really a ceiling effect. Steve Mallon came along immediately afterward and said, well, if the effects of, or if metformin blunts the acute effects of exercise, what happens if you do training? So he did a similar study with people with prediabetes, 12 weeks of training with or without metformin, metformin only in a control group, and again measured insulin sensitivity with glucose clamp and isotopic tracers, and found a very similar thing with 12 weeks of training. This is the control group. They got a little bit worse, which makes sense over 3 months. The metformin had an effect this time. 3 months of metformin increased their insulin sensitivity. Exercise in the placebo condition did a great job of increasing insulin sensitivity, as it always does. And once again, we saw a blunting effect when we added the metformin. You know, we did not see the full effect of exercise manifested with the metformin. And this wasn't just with insulin sensitivity. This was with LDL cholesterol and HDL cholesterol and triglycerides and blood pressure. There were, you know, 7 or 8 outcomes we had, all of which were blunted when the metformin was added to the exercise training. And we've been very heartened, we don't have an explanation for this, but we're sort of working with the idea that there's some restriction on cardiorespiratory fitness when you have the drug on board, that you don't see the same effect or the same adaptations to training. So one piece of evidence is that we had a reasonably strong relationship between change in VO2 peak and change in insulin sensitivity, explained about half of the variability. The exercise in metformin group only increased their VO2 peak by 10%, the exercise in placebo group by 20%, even though they did exactly the same training over 12 weeks. So we're sort of working with the idea that metformin blunts insulin sensitivity by somehow constraining the adaptations to training. And in a way that's really heartening, this has now been recapitulated in several venues. Dr. McCulley's familiar, certainly, with that statin drugs seem to blunt the effects of training on mitochondrial function and proliferation, and John Tifo showed the same. Resveratrol and exercise don't seem to be as potent as exercise alone, and there's been several pretty big trials showing that exercise training with antioxidants on board blunts the effects of training as well. So there seems to be these sort of interactions between medications and exercise that may constrain the typical adaptations to endurance training that then, you know, result in a blunting or attenuating effect on some of these health outcomes. This is important because, as I point out to pharmaceutical companies all the time, when their drugs are approved, the USDA uses the same language, right? The U.S. Food and Drug Administration says, the U.S. Food and Drug Administration today approved, fill in the drug, used with diet and exercise to improve glycemic control in adults with type 2 diabetes. Every single diabetes drug is approved with that language, and they've never done a study looking at the drug in the context of diet and exercise. So do they test its efficacy or safety in this context that it's been approved in? And the answer is not to date. And this was going to be my chance to go on a great rant about the wild west of drug and exercise interactions, but then I talked to Ira Jacobs and realized I was going to be giving his presentation. So I'm going to stop right there and thank everyone for their attention.